Thank you, everyone. Oh, something in the mic, there we go. So we're going to start today by, I think, with a video that was created that describes the JI Rise initiative. So for the talk, we are going to speak to the points that Tim discussed about the kind of the way in which conflict is changing and how those patterns are informing the role of academia in humanitarian response. But before we get into that, we'll just start, hopefully, with an overview of the JI Rise program in video form.
Airstrike struck Gaza's biggest hospital.
Mr. President, the Security Council today begins its history.
Plainclothes security and uniformed
Image destruction that will take years to rebuild.
There is no accurate data on how many have been killed.
Out of 36 hospitals in Gaza, at least 20 have been destroyed or are out of commission.
Okay, thank you. Oh gosh, that's a bit tall. Okay, thank you, everyone. My name is Bhargavi Rao, and I'm both at the London School and also head of research for Médecins Sans Frontières. So I think one of the things we wanted to bring to the work that we're doing is very much that this is engaging many implementing partners, agencies on the field, and very much looking to answer the sorts of questions with an academic rigour that many of the agencies are requiring. And just to sort of give a brief overview, because many of you may know these statistics already, but by about the middle of 2024, there were about 120 million people forcibly displaced globally. That's about 1 in 73. 300 million people globally in need of assistance, and 1 in 5 children globally fleeing conflict. Over 260 million facing acute food insecurity, and all the while also combined with outbreaks, which are deadlier within displaced populations than in host populations, often coexisting multiple outbreaks all at the same time, and sort of made even worse by very fragile health systems, which are increasingly being targeted through the sorts of conflicts that we're seeing in Syria, Ethiopia, Gaza, of course, we'll come on to. And then an incredibly poor system responsiveness for funding, which is in part some of the work, sort of some of the reasons that are fueling what we are doing. Those of you who may know the humanitarian sector will know that in order to gain funding for programs or for research or for anything like that, the amount of data, the amount of planning that needs to go into developing these proposals, which then go to funding, and it's not until many of these crises occur that actually the funding, the sort of funding system is ignited or started. This leads to sort of huge delays in getting vaccines to people that require them, up to 50 days for cholera, which is catastrophic given the fatalities associated with outbreaks. But also it means that there's real delays in water and sanitation interventions, and even just getting staff to places that are required. And that's added to the fact that there is increasingly limited funding for humanitarian crises. In fact, last year was the first year in which humanitarian assistance fell since 2000. So we're facing an increasingly difficult and limited challenging situation. And just, I mean, Gaza is obviously all over our news at the moment, but just to sort of put some of this into place, this is a one year since this current crisis developed. And what we know from the 1 year report is that we have over 41,000 deaths, of which at least 11,500 are children. These are really appalling statistics. We have almost 2 million people displaced in Gaza, and what is really different is that these people are displaced almost on average once a month, which is something that we've really never seen before. That level of brutality and distress in being repeatedly displaced again and again. There are almost 500,000 people facing famine in Gaza, and I don't use that word lightly. This is IPC level 5, with vaccination coverage dropping, and so this population is at huge risk of outbreaks. We're already seeing over 50,000 cases of hepatitis A. We've seen a case of polio. There are acute respiratory illnesses, many infectious diseases really running riot within these displaced populations, which are even more challenged by the fact that there is barely a functioning healthcare system in Gaza at the moment because of deliberate targeting of hospitals, healthcare workers, and primary healthcare facilities. And needless to say, just catastrophic water and sanitation situation also, which is fermenting the problems even more. So on the basis of that, I'm going to hand over to OJ.
So, in response to the situation that has been continually developing in Gaza, earlier this year, the team at the London School of Hygiene and Tropical Medicine, supported by the UK FCDO, had started working in a responsive pattern to better understand the likely onward trajectory of the conflict. It was about this same time, in January, February 2024, that also we were in discussion with Community Jameel and the team at the London School about what were actually really the unmet needs that they were finding in their research. So they were really focusing on what likely would continue to happen under different scenarios for the escalation of conflict or ceasefire. But while doing that work, they were really coming up against a number of shortcomings and gaps and tools really that they found would have really enabled them to have responded much quicker to the situation as it was developing, but also in a way that was going to help them prioritize and sort of give advice and guidance to the humanitarian response. And so on the backdrop of this, and through discussions with a number of international agencies, we, Bhargavi and myself, put together a program of work, which is what the JI Rise initiative speaks to. And so its general purpose was really motivated by the situation as it was developing at the beginning of 2024 in Gaza, but more broadly was about developing tools that would be more generally helpful across conflicts, and also more concerningly really in response to the way in which conflicts are changing and have been changing over the last few decades. And within this, there are three main aims that we've decided upon. But importantly, again, these are aims that are kind of continuously developing, right? These were a set of work that was clearly very important in the first half of 2024 in Gaza, but as the situation develops further, these are continuously being thought about, and we are responding in a more reactive way to actually what are the current needs. But the first is, and we'll talk through each of these, and the reason for doing this as well is because everyone here in this room hopefully are individuals who are interested in this, but also individuals who may be interested in some way in collaborating, partnering, or adding insight into these aims. So the first one on vaccine-preventable disease modelling, so trying to provide tools to give supports to understanding the risk of different vaccine-preventable diseases as conflict starts to break down vaccine coverage. Improved usage of sort of mortality data. So there was clear want to understand actually the impact in terms of direct mortality, but actually what are the methods by which we estimate mortality in humanitarian crises? are these ones that we can rely on, and how could we address some of those gaps again through developing new methodological tools. And the last aim on really a broader evidence framework for humanitarian response. So if there isn't a strong, robust health system prior to the start of conflict, it's often very hard to understand how best to respond and prioritize humanitarian agencies when conflict breaks out. But are there general patterns when we look across the last 20, 30 years of conflict to better understand what should be the likely drivers of morbidity and mortality, and ones that we can then provide that guidance for prioritization to aid agencies? And while this was a scheme of work with obviously a primary focus and driven by the situation in Gaza, again, it's really about trying to be reactive to where support is most needed. So throughout this, we'll be considering as well partnerships with often groups within the London School of Hygiene and Tropical Medicine who are supporting work within Sudan and other locations. But again, thinking about how, when providing these methodological and research aims, how we can also embed within that a practice of capacity bridging within individuals who are directly being impacted by these conflicts. In the interest of time, since Tim has mentioned, well, we're running on a minute-by-minute schedule, we'll just skip through. But the real aim, hopefully, with each of these aims is that they're not sitting in a silo and trying to think about how, for example, a broader evidence prioritization framework for how we respond can also then be fed into by a vaccination tool that understands what are the main drivers or likely drivers for vaccine-derived mortality over a time frame. So just to say, while each aim is going to be described in silo, we are really trying to think how they all bring together to provide support both to Gaza, but more broadly in contact and conflicts more widely. So on the first aim, the vaccine crisis modeling aim, there we go. So this was really motivated by discussions with some of the people you'll hear about today later in the panel, with Olivia Dupin, about do we have an ability to provide guidance around what vaccine-preventable diseases require the greatest prioritization when there is a change in routine vaccination coverage. That may be driven by the cessation of vaccination due to conflict, or it could be just due to consistently low vaccination coverage in areas that are consistently being impacted by moments of crisis. And the hopeful aim of this is then a tool which it will support humanitarian partners and aid agencies to kind of visualize the timelines to risks for new outbreaks of vaccine-preventable diseases as a result of those reductions in vaccination coverage. So Bhargavi already mentioned that we are seeing now below 90% coverage for routine vaccination in areas of occupied Palestine. And these numbers that are sort of shown in the bottom right, these are estimates for really for the end of 2023. So that dip is really just being driven by what didn't happen in the last few months of 2023, and likely these are now much lower than these percentages. And what this then means is that we are going to start seeing outbreaks of vaccine-preventable diseases, but which are going to be happening first, and which ones are going to be most likely to take off, and which ones are thus the areas where targeted interventions and new reactive vaccination drives should be focusing in order to prevent those outbreaks. For the next two aims, I'm going to pass back to Bhargavi.
So aim 2 was originally to assist some of the mortality estimation that was required within Gaza earlier in the year. As time has evolved over 2024, we're having to adjust this aim somewhat. And so what we're actually going to do is to look at some of the published mortality estimation in a variety of humanitarian settings, including Gaza, and then review the methodologies that were used, firstly to provide better guidance for agencies, for academics, for people on the ground to actually analyse more effectively. But I think the other thing that's really driving this is also how little some mortality estimates seem to shift the needle in terms of policy. And I think what we really want to also look at is how do we make mortality data sort of more usable and to have greater impact for policymakers. And that might be including developing decision tree frameworks and things like this for different stages of crisis, so that actually these estimates have some sort of policy meaning, that people can actually use them. We're going to also look at different types of methodologies such as capture-recapture and record linkage options for mortality estimations, and start to sort of bring those together and evaluate what is required in different contexts and what are the gaps. So, for instance, already we know that there's issues on open source tools with the use of Arabic. And given that some of our focus is Gaza and Sudan, this is clearly something that already we can say is important. And then finally, and perhaps a little bit less related to mortality directly, is that Médecins Sans Frontières actually came to us to say, we really need help with estimating mortality from trauma in these areas. And so we're going to